Hi, so my name's Jane Waite. I'm from the Cerebra Centre for Neurodevelopmental Disorders. And today I'm going to talk about how to spot the signs of anxiety disorders and what can be done. And this is based on the parental guide we did for Cerebra, my colleagues and our team put together with Cerebra's help around identifying anxiety disorders. There's a focus in this presentation on people with more severe to profound intellectual disability. However, a lot of the themes are also relevant to a wide range of ability levels as well. The other thing I'm not going to talk about today is medication, because I'm a clinical psychologist. It's not my background, but that I don't have any strong feelings for or against medication, but I won't be covering it as part of this presentation. So I'm going to start with some very basic stuff, but I just want to start, right at the beginning of thinking, what is anxiety, and when do we experience it? And anxiety is a very, very normal part of life. It's when we perceive a threat in the future, and we anticipate that we might be at risk. So we might need to either prepare ourselves and get ready to fight that particular threat, or we might need to get away from it and avoid that particular threat. And when people are anxious, there are a number of different changes that happen. So changes to the body, changes to the way people think, and changes to people's behaviours as well. And these are things that you might recognise in yourself or other people that you've worked with or your children. So changes to the body include that fast heartbeat, maybe sweating, muscle tension, and sometimes things such as having an upset stomach can also be associated with anxiety. The changes to thinking patterns that we see are often more repetitive type thinking, or an inability to concentrate. And we might see a change to a range of emotions that go alongside anxiety, not always, and sometimes occur in other situations too, but things such as irritability, distress and being upset often co-occur with anxiety as well. And then changes to behaviours, such as avoiding certain situations, being more fidgety and restless, and maybe that impacting on sleep as well. So we can see that there's a broad range of impacts of anxiety and things that we can look out for. However, when children are non-verbal or minimally verbal, it can be much more difficult to identify many of the signs of anxiety, and that's because things such as thoughts and emotions might be difficult for that individual to articulate, or it might feel different how we perceive those emotions. So it makes it very difficult as professionals and as parents to know necessarily whether our children are experiencing those difficulties. There are some studies that have looked at in more people with that are minimally verbal and or non-verbal around the signs of anxiety. And some studies have shown that anxiety might look quite similar in terms of behavioural markers. So this is what we're left with in the end. We have to look at those behaviours. So things such as reduced eye contact with others, maybe reduced length of speech, signs of physical discomfort, or wanting to be in proximity to a familiar person. There are also studies, particularly with higher functioning autism, that have shown that there might be other behaviours that we might not necessarily think of as indicative of anxiety, but might be important to take into consideration. So, for example, some recent research that's been done up in Newcastle has shown that repetitive behaviours, whilst being part of the triad of impairments for autism, often increase when somebody's anxious. So they're correlated with anxiety. So these are specific behaviours that we might just need to keep in mind. It doesn't mean that they are related to anxiety, but that we should be thinking about if we see a change in our children's behaviour from baseline. However, we have this other issue that when we're looking just at behavioural markers, that then we get a bit stuck sometimes, particularly when anxiety is quite general and pervasive. In non-verbal or minimally verbal children, do we know whether or not these are definite markers of anxiety, or could they be indicators of pain, low mood, or again that overlap with autism spectrum disorder? So how do we tease that out? And that's something at the moment I think we're not very good at doing in people that have difficulty communicating internal states. and something that I'll talk about towards the end of the presentation, how we're hoping to improve that process of assessment through the research that we're doing currently at Birmingham. Importantly, anxiety, as I said at the beginning, is really an important, it's very much an everyday part of life. And on this left-hand side of this table here, we can see examples of anxiety that we all experience. And then on the right-hand side, we can see examples of when anxiety becomes a clinical issue or a difficulty. And the main thing is that impact on quality of life, so that anxiety starts to impact across a broad range of areas for the individual. So, for example, if somebody is anxious about crowds, then that will impact on their ability to seek out social support, on their ability to maybe engage in activities they enjoy. So it has that pervasive effect on all aspects of that person's life. And what we can do, what's been spoken about a little bit this morning, are different anxiety disorders. So it's possible to categorize these into different anxiety disorders based on the presentation that we see for the content of the worries and the different presentations across those anxiety disorders. I'm not going to touch on that much today because you can read about that in the anxiety guide that we've produced with Cerebra. But I just wanted to acknowledge that, but also say, at the moment, we don't know whether these categories really map on well for people with more severe to profound intellectual disability. So, and that's something that where these categories can be a very useful shorthand for maybe understanding or thinking about clinically the profile of anxiety that someone's experiencing. But we need to do more research about whether these categories really do capture, from a bottom-up perspective, how anxiety is experienced by people that are non-verbal. This has been covered this morning, so I'm not going to spend too long on this, but just to give an idea again about the statistics of anxiety in relation to typically developing adults, so children, sorry. So we know that 1 to 3% of typically developing children experience anxiety. And in a group of 100 people with intellectual disability, then the ranges are from 3% up to 20%, but depending on the study and the methodology used. In autism, that goes up to 40%. And then there are specific rare genetic syndromes that we study in Birmingham where we know that there's an association between anxiety and that genetic syndrome, as Andrew discussed this morning. And so in Williams syndrome, Fragile X, and Cornelia-de-Lange syndrome, we see ranges from 60% through to 80%, highlighting that for some people there is a clear genetic link with anxiety. So this has been covered a little bit this morning, in fact quite a lot this morning, in terms of why anxiety is potentially more prevalent in people with intellectual disability. So there's a broad social factors that Richard spent some time discussing, and then also differences in how information is processed in the brain. Emily discussed a little bit about executive functioning and how that potentially can impact on anxiety and the association in autism. So we've got to think that when people experience anxiety, it may be because of some of those differences in how individuals process information, so differences in short-term memory, the ability to hold information in mind about the potential likelihood of a threatening situation occurring, the potential costs to that individual if that was to occur. And also thinking about, for people sometimes that who are anxious, the way their attention is allocated to specific stimuli in the environment might be different. So it might be more focused on anxiety provoking stimuli, whilst ignoring the other things that might be that might counteract the impact of that stimulus. Finally, the other thing to say around this is that there's some evidence now in autism that early sensory processing difficulties might be a potential risk marker for the development of anxiety later on. This is very early research, so it's only been published in the last couple of years, but it's also important to think about in terms of if that could be potentially something we should be following up with families. But there's a hypothesis that different brain circuitry might be associated with those sensory processing difficulties, and that those changes also overlap with anxiety circuits in the brain. Okay, so that's the brain. And then, of course, you've got the differences in adaptive ability that people with intellectual disability might have, including communication. So even if information's being processed at a brain-based level, then differences in how that individual may then be able to cope with that particular anxiety-provoking stimuli or anxiety-provoking situation could result in anxiety. So if you don't have the skills to then be able to actually transform your world and to manage that anxiety that you're experiencing, if you can't problem solve in quite the same way, then you're going to likely be more anxious. And then this leads to a natural kind of skill environment mismatch where the world might be more demanding necessarily than the world might be more demanding in relation to the skills that somebody has. And people with intellectual disability might have less opportunity to make choices as well. And if you don't have choice, we know that low controllability is associated with anxiety. So all of these things coming together, we can see how that can then influence anxiety. Okay, one thing I just want to talk about very quickly is research recently that's looked at intolerance to uncertainty. So it relates to this issue of controllability. In autism, there's been some interesting work done that suggests that controllability and this idea that if you have difficulty tolerating uncertainty, this is associated with anxiety. That makes a lot of sense, obviously. But this idea of intolerance to uncertainty is important because it may impact on the types of interventions that we want to do. Okay, so here is an anxiety cycle. And some of you will be very familiar with this. So here's a situation here where a parent may, this is for a simple phobia, so we'll cover more general anxiety in a moment, but a parent may take their child who has a phobia to the park. The child has a phobia of dogs. The child's heart rate starts to increase. They feel tense and worried. They get hypervigilant. That child may then engage in behaviours to show their distress, but also because those behaviours are associated with the removal from the park, which then leads to a situation where next time the child might be more likely to show those behaviours again because they lead to that anxiety-provoking stimulus being removed, which is the park and the dogs particularly. And over time, a child might lose confidence in terms of their ability to cope because they're not having experience in those anxiety-provoking situations where they can learn that they have the skills to be able to overcome those obstacles. So what do we do about it? Okay, so what we've talked about this morning is about cognitive behavioural therapy, which is can be very appropriate for people with higher functioning autism. But only, I think Emily picked up when there are adaptations made to the cognitive behavioural therapy, such as using very concrete language, using pictures, involving parents, or also including the child's special interests in the CBT. For children that are less able, often graded exposure is used. So this is a form of desensitization where the child is gradually exposed to the anxiety-provoking stimuli. But this is done in a way, so we wouldn't just throw a child into a situation where they're suddenly overwhelmed with whatever the anxiety-provoking stimulus is, because that would not be very ethical and probably would not be that helpful. So what we would do is we would break down that into a number of very small incremental steps. So the first step might still simply be walking past the park. The second step might be staying there a little bit longer than before. So until the young person feels comfortable in that situation. and then you gradually increase the exposure to the anxiety-provoking stimuli. And you would do this alongside relaxation training to give the person skills to help them regulate their emotions, and skills development, so maybe being able to ask to get out of a situation that could be particularly difficult, or new ways of coping with situations that produce anxiety. So it's a double-pronged approach. It isn't simply just exposing somebody, but it's exposing somebody and empowering them by giving them the skills to manage that situation. And this can take a lot of time, so you have to go very, very slowly. So even a trained therapist, it could take, when you look at research articles where this has been done, sometimes it's 26 steps over 36 sessions. And it's very, very incremental, so it does take a lot of time. And one thing I've really heard today is, what I was going to say at this point was get support from your local CAMS team, from a clinical psychologist, from a behavioural support team. But I'm just a bit cautious about saying that, just because I know a lot of you have potentially not had great experiences with that. But it is helpful if you can get that support to do that in collaboration with somebody who can guide you through that process. Giving choice is important. So this is all about controllability, so trying to increase controllability. So, for example, one girl, she was really struggling around dinner times and was anxious that she might have to eat a food that she didn't like, so really because of the texture, non-preferred food. And simply giving a choice before dinner time between the non-preferred food and the preferred food increased her sense of controllability enough that her anxiety decreased around dinner time. It's a really simple intervention. It's probably things that you've tried, and it won't work in every situation. But for some individuals, just having that choice, being able to communicate, may be enough to bring anxiety down. And then the final thing I want to talk about is this idea of increasing certainty, and how that might overlap with some of the research that suggests that intolerance to uncertainty might be associated with anxiety and autism. So typically, interventions around decreasing anxiety in autism have focused on trying to have predictable routines, visual timetables, with the sort of reasoning that if the world is very predictable, then anxiety will decrease. And I'm certainly not suggesting that we shouldn't be doing that anymore. I think that's very important and part of any intervention package to manage anxiety. However, if we accept that potentially intolerance to uncertainty could underpin some of the anxiety that people are experiencing, and we know that exposure to the things that are difficult or anxiety-provoking helps to reduce anxiety over time, so you're breaking that avoidance cycle. By having predictable routines, in some way, what we're doing is avoiding uncertainty and not decreasing anxiety over time. So it kind of feeds into that cycle, potentially, of maintaining anxiety. So I think routines are great, but we also need to increase flexibility within those routines. So, and that might be planned flexibility, so having a visual timetable that has a question mark day, or even just a question mark 5 minutes where something unpredictable happens or a new activity is brought in, or varying activities just a little bit to allow people to develop that sense of tolerance for uncertainty, so that people over time don't become too rigid and don't find change too difficult. And I think we're walking a really fine line potentially between those two positions, and it's difficult to balance, and we need to understand more about how intolerance to uncertainty might be associated with anxiety. And just to say, intolerance to uncertainty as well isn't just associated with autism, but it's been associated in typically developing children with anxiety. It's also been associated with adults who don't have intellectual disability with anxiety. So it seems to be quite an important construct for us to unpick and try and understand in the children that we support. Okay, so just to summarise, I mean, the key messages I wanted you to take away from this presentation were that there are effective interventions for anxiety. It may the type of intervention may depend. I've given an example of a specific phobia today, and that's a lot of the anxiety that people are experiencing is much more pervasive, heightened levels of anxiety across situations a lot of the time. A specific phobia is just one discrete anxiety that has a very clear intervention structure. So that, but underpinning anxiety, there is always a sense of avoidance and avoiding things that produce anxiety. So, and therefore, if we can tackle avoidance in some way, that helps to reduce anxiety over time. The other thing that I wanted to get over really was that we're still very early on in being able to identify anxiety well in children that have difficulties with communication. So we need to really push that forward as a research agenda. And in Birmingham, we're working with Cerebra at the moment. We've got 2 PhD students who are trying to understand the behavioural markers of anxiety in non-communicating individuals, and to look at whether we can validate those behavioural markers using things such as physiological measurements, so things like heart rate, cortisol measures, galvanic skin response, so that we can get better at this. And even if we just find that we're seeing very similar behavioural markers in children with more severe to profound intellectual disability, we might be able to streamline the assessment process so that more people are identified. Because at the moment we feel that lots of people probably are being missed because anxiety isn't being identified early enough. Okay, I'd just like to thank my team who have been nodding at me at the back, ironically so I don't get too anxious giving this presentation. I'm not sure it actually worked, but thank you. And just to Rachel Royston and Hayley Crawford, who have put a lot of work and time into the ideas that I've presented today.